Hello, everyone. I'm Dr. Bill Beakey, Director of Professional Co-op, and welcome to today's webinar with Dr. Brandon Lundell, Decoding Longevity and Using the Key Biomarkers for Optimizing Healthspan and Lifespan. I know I'm really interested in this. I know a lot of you are, and your patients will be as well. And who better to tell us about this than Dr. Brandon Lundell? He's got a fabulous practice in beautiful Longmont, Colorado. He's spoken at numerous conferences. He formulates nutritional products. He lectures for NutriWest and Doctors Data and the DAPSI program with Dr. Bill Kleber. And we're extremely fortunate to have him as part of our PCS family as well. He's got numerous videos on our video library, so please go back and check those out. He's done a fabulous job for us, as has all of our other speakers as well. So we're very proud of that series, and couldn't be more happy to have Dr. Lundell join us today. He's also developed his own certification course called Nutritional Pathology, and the next version of that is going to be coming up in February. And he has a really excellent annual online seminar that he gives, and that is coming this Saturday. And that is his annual Functional Medicine Practice Accelerator. And, you know, I guarantee that will be a very big help to a lot of you. So consider taking that. And anything else that Dr. Lundell does, you'd be very wise to participate in. He's a fabulous researcher, lecturer, and clinician. Welcome, Dr. Brandon Lundell.
Yeah, thank you. Thank you, Bill.
And
yeah.
We also have some other webinars coming up with Dr. Bill Kleber and Dr. Ruth Kriz. And if you didn't see the last webinar we had on the next-gen sequencing and PCR testing for chronic infections, which compares samples to 57,000 bacteria and fungal pathogens, and they're going to be adding in viral pathogens as well. That is on our website. Please do take advantage of that. And Ruth Kriz, nurse practitioner, will be back with us on January 16th with a part 2 of this. This is really fabulous material, folks. So please consider watching those as well. So without further ado, Dr. Lundell has plenty to talk about. So thanks for being with us, Dr. Brandon Lundell.
All right. Thanks, Bill. Yeah. And thank you for all you do. And that test you're talking about, checking the blood for infections and you know, bacteria, viruses, that's going to be so helpful. So many people and have multiple viruses, multiple bacteria that don't show up in any other tests. So that's going to be really cool. And that is part of aging as well, which is the topic today. My objective today is to help simplify this difference between biological age and chronological age, which is a very helpful clinical tool and clinical paradigm to have in our clinic and for our patients and for ourselves too. You know, how am I aging? Am I aging accelerated, or where do I stand among, you know, the average person? But there's a lot of different tests out there, and it's very hard. It's an evolving science. How do we quantify, you know, where we're at and how we're aging and how the cells are really functioning? So today I want to go over some key biomarkers that we can use on a daily basis. You know, regular blood tests that we run every day. There's a lot of fancy tests that we'll go over a little bit today. I'll give you kind of the general overview of biological clock medicine right now, or biological clock laboratory medicine. But there's tests that we run every day that we don't fully understand. I think a lot of clinicians don't fully understand the clinical utility of running these and being able to evaluate a person's longevity and health span score, if you will. So we'll identify the major biological and lifestyle factors affecting health and longevity, at least as much as we can do in an hour or so. It's a very big topic, obviously. But I want to help everyone listening to integrate these simple biomarkers into your practice and how we can use these biomarkers to motivate our patients and to educate our patients on where they're at. That's one of the most clinical, useful pieces of these biomarkers, is to motivate and educate our patients. And we'll go through some clinical therapeutic interventions too, lifestyle, biochemical, psychological, cellular optimization. I'll give you some clinical pearls as well. We don't want to walk away with just a lot of knowledge. Let's be able to apply all of this. So obviously there's a difference between health span and lifespan, unless you've been living under a rock. We do know now that our rate of aging is quite different. We used to think that aging was, for the majority, determined by our longevity genes, right, and inflammatory genes. But we now know that, of course, the epigenetics is far more important. But the two interplay significantly with each other. So what's interesting is that the global lifespan is kind of plateaued.
Brandon,
what's that?
Notes and video will be on the website later today, or maybe tomorrow at the latest. So sorry for that, and I'm going to get off camera and let you go ahead. Okay, cool. Yeah. We'll get the notes for everybody, so you can. We have a lot of notes to cover today. A lot of it will be just for references, but. But what's interesting is that as the lifespan has been kind of plateaued in the last several years, the health span has been decreasing. The World Health Organization, for whatever they, however they assess it in many different ways, the average global lifespan is 73, but their version of lifespan is 63, but they're only looking at disease. How many disease-free years? That doesn't mean that you have a good quality of life and that you're thriving. So when we look at quality of life and thriving measurements, really the average health span is just 35 years. We can do better than that, right? That means people only can expect today to have 30 to 35 years of feeling good and being able to meet life with their full complement of faculties. And that's not, we can do a lot better. So we have this normal aging today, which is the blue part is normal or optimal functioning, but then most of the end of our lives, or several red parts throughout our life, where we get these age-related diseases or chronic diseases or even acute diseases that can be avoided. And so the goal is to make this red and blue pretty even. And this is another one from Peter Attia's book that a lot of people have read. But it's a good schematic here of, normally at about 20 to 30 years of age, people's average health just starts to decline significantly. And that shouldn't be the case. We should have well-functioning, thriving for most of our life until the very, very end. And then it comes down here. So that's what we're going to talk about today, is being able to assess where somebody is at on this curve, if you will. Now, this is interesting here. I just put this study up because there's always been this difference between males and females, and women's health is getting finally a lot of deserved attention and focus, because a lot of medical studies have been focused on males. But male health has continued to suffer. Why do we not live as long? There's no genetic reason that males should not live as long as females. And it really comes down to, I think, how we raise boys differently from girls, and, emotional health and lifestyle health and those kinds of things. Of course, occupation and that kind of stuff is a part of it too. But male health also needs to be addressed. Males do tend to be more affected when it comes to endocrine disruptors. So I think toxins and toxin exposure is also another key indicator of that. So this is an increase, really interesting. It's an increasing disparity between biological and chronological age with advancing years. So this is called age acceleration variance, or your biological age heterogeneity. You can see here that at around 20,
most people are aging at around the same rate. I mean, unless you start smoking when you're 10, right? Most people don't do that unless you're from the Philippines or something. But at around 25 here, you start to see this huge variance between, you know, someone at the same chronological age, but biologically their cells are expressing much differently. At about 30 years, when you're 30 years old, there's on average a 10-year variance between people, right? So you can be 30, but biologically you could be, you know, 25 or 35 or 40. So, or even 45. So by 50, it's around 30 years difference, and 75, it's 40 years difference. That means somebody at 75 could be expressing 50-year-old genes or 90-year-old genes. So this is really very interesting. This is plotted from a lot of data about what we'll get into is methylation marks on your genes, which is a very, very good predictor. It came out of forensic medicine, looking at, well, how can we tell someone's actual chronological age if we don't know, like Jane Doe's, or so forensic medicine started this field of how can we tell someone's chronological age, and methylation marks become on CPG sites become a very good gold standard. But as they got into it, they're like, wow, there's a huge variance here, and why is that? So we'll get into that. So biological age versus chronological age reveals aging rate across multiple systems, identifies accelerated aging before disease manifests, right? That's functional medicine prevention, provides actionable markers for intervention, allows tracking, helps prioritize what parts of the cell and what parts of the what organ systems are accelerated aging versus others. That's another important point. Our cells, parts of ourselves age very differently. Our brain and our heart and our liver and our spleen, they all age at a different rate, and that can be affected a lot by our epigenetics, which we'll talk about today. And this is kind of my Healthspan quadrants, the 4 things that we want to look at and address when supporting someone's health spans. Category 1 is this molecular and cellular optimization, looking at mitochondria and autophagy and methylation, your diet, the microbiome, those kinds of things. Category 2 is your lifestyle factors, exercise, sleep, social relationships. Category 3 is these technology and technological advancements, labs and future determinants, things like cryotherapy and infrared, breathing, looking at labs like CRP and homocysteine that we'll talk about today, using hyperbaric. So these are technological categories that we can use. Category 4 is your psychosocial, psychological, and social, your relationships and your cognitive stimulation and preservation. But these 4 areas are the major factors in aging and health span. So, so let's focus today on age clock biomarkers in functional medicine. The lecture that I'm going to give this weekend on Saturday, I'll go more into Healthspan and senolytics and senescent cells and those things, and give you even more clinical actionable tools. But today I want to focus on what biomarkers are the most accurate in understanding our age clock. So there's many different major biomarkers in predicting and measuring your health span and lifespan. So the first is the transcriptome tests that look at things like microRNA, and then there's the proteome tests that look at your proteins, and I'll give examples of these. There's metabolomic tests, glycomic based tests, so measuring glycation on your cells and on your genes, specifically on your immune cells and antibodies. And then there's these epigenetic clocks or methylation clocks, and then there's telomere lengths that we all know about, but telomeres are actually starting to become as we understand more, less accurate, less favorable. There's too many variables. It is a piece of understanding how quickly your cells are turning over, but because we can add and take away telomeres epigenetically, that doesn't become a good, snapshot of where you are at, like we thought. When it was first discovered, we thought, oh, this is your biological clock, and while it's a piece of it, it's not as accurate as we thought. And then today I'll talk about composite biomarkers, things like everyday labs that we run, how useful they can still be. It's kind of coming full circle to, yes, there's these fancy and new and exciting transcriptomes and glycomic and epigenetic clocks that will continue to be developed and have more clinical utility. But when we circle back to our daily labs that we run every day, like CRP and hemoglobin A1C and those things, they actually have as good of a correlation, if not better, in many ways. So now, ideally, composite biomarkers will take into account all of these things, which we'll talk about. They're not out there. It's not out yet. So the best we can do is kind of do it ourselves. So, but transcriptomic tests measure the RNA levels, what's active in your genes. Proteomic testing, it measures proteins and their modifications, inflammatory proteins, growth factors, cellular senescent markers like tumor necrosis factor alpha. These are proteomic tests, right? These are all the proteins, mostly inflammatory, that our body is producing, and we'll talk a little bit about that today. Metabolomic tests are looking at things like amino acids and lipids and nucleotides and organic acids. So that's the metabolomic tests that are also extremely useful. But these all come with a little bit of a caveat. One, they're expensive, they're not accessible on an everyday test. So my goal today is to, even without these fancy tests, or if you want to incorporate these fancy tests, can we use these simple everyday tests to accurately predict somebody's biological age? Glycomics is very interesting. IgG glycosylation marks, fucosylation marks. These are pretty accurate predictors of biological age. So and how fast we're aging. Let's see. We've got the telomere length, as I said, or that's known as mitotics, measuring mitosis and how many times your cells are turning over. And you can also, in addition to that, measure telomerase activity. So that's that's more useful than just telomere length. And then finally, we have these epigenetic clocks, and it measures. And these are really interesting. These are becoming more and more common. And more and more advanced. So we have these CpG methylation sites. These are the most active regions of cells, but there's predictive age-related methylation changes. So Horvath clock was the first to come out in like 2010 or so, and then Horvath is a researcher who the latest is his GrimAge. And it looks at many different DNA methylation surrogates and also some clinical markers. And then PhenoAge is also out there. And then the latest is this TruAge. It's a more composite testing because it does take into account not just your genetic methylation marks on the CpG sites, but also some of the blood testing on a daily basis, and also even some clinical questionnaires and things like that. So it is more of a true composite test, but it hasn't been put through rigorous studies yet, and it's fairly expensive. But these are good tests. And think of it this way: transcriptomics are what genes are active right now. Proteomics are what proteins are being produced. Metabolomics are what small molecules and metabolism are present. Glycomics are what sugar modifications are happening, and it's due to glycation and the amount of sugar in your body, and that's probably the first clinical pearl I'll tell you, is that the number one cause of aging, or the biggest cause of aging, is just the amount of sugars that people eat. Hemoglobin A1C and fasting blood sugar continues to remain one of the most reliable markers of aging and cellular function. So telomere analysis, how much and how quickly the cells are turning over, and then epigenetics clocks, or which genes are allowed to be active. So let's look at our testing that we run on a daily basis using accessible blood tests to evaluate and treat accelerated aging. So these are the ones. So I've been studying this for years and refining these algorithms that I'm going to present today, that anyone can use in your practice. You know, what's weighted more and what's more important, but these tests can very accurately predict someone's biological age. The key benefit of these is they're readily available, right? You just go down to LabCorp and you have all of these tests available. They're more cost effective than some of these specialized aging tests. They provide immediate actionable data, and it captures these main pathways: inflammation, protein status like albumin and globulin, glycation, metabolic health, kidney function, cellular turnover like RDW and ALK-Phos, methylation status, and some nutrition status like vitamin D and phosphate. So in this study, deep biomarkers of human aging, these standard blood markers can predict mortality with over 80% accuracy, which is similar to these fancy biological clocks. The top 5 by Putin, not that Putin, but this researcher Putin, was albumin, glucose, ALK-Phos, urea, and red blood cell indices. So looking at these predicted aging and death with over 80% accuracy, if you know how to interpret it. Albumin alone predicts 10-year mortality with a hazard ratio or odds ratio of 1.84. That's 84% predictive. So pretty fascinating there. Albumin, for those DAPC students out there, albumin is one of the ominous signs that we see when albumin starts to drop significantly. That's not a good sign. Better correlates with functional status. Even it would actually be more in terms of 95% accurate if we didn't look at just mortality, but we looked at health and vitality and the aging process. So we also want to integrate, of course, I'm not saying that biomarkers are the only way that we can assess, or the only way we should assess the health of an individual, the age of an individual, or the predictive future, lifespan or health span of an individual. I use in my practice symptom questionnaires, and I am developing, an AI program that will take all this data, and that's kind of what TruAge does, and a lot of these are machine learning models and AI models. But the more these machines learn and AI learns about incorporating all of this data, it's scary accurate. I mean, scary accurate. So we use symptom questionnaires. Do you wake up in the morning tired, or how long does it take you to get to sleep? Are you stiff? Do you have a runny nose? Constant runny nose, which is a sign of leaky gut. All of these things are taken into account. SNPs also are important, but certainly SNPs are your genetic code and not your phenotype, right? The difference between your genotype and your phenotype. We also look at physical exam findings, right? The BMI is really predictive of age when you get outside the first standard deviation. So blood pressure, grip strength, sit and reach test. There was one of my favorite tests is predicted mortality with like 80 to 90% accuracy. Just if you sit and you bend, or you sit and your legs are outstretched in front of you, and if you couldn't, your score on where your hands were, right? If you could only go like this far versus touching your toes, that predicted cardiovascular death, because your flexibility, your body's flexibility, is reflected in also your cardiovascular flexibility, right? Stiff arteries, stiff heart muscles is really the main clinical manifestation of cardiovascular disease. So it doesn't mean that if you just sit and practice the sit and reach test and you get better at that one specific test, you're going to have better aging. Just like the grip test, you can't just, if you have a weak grip, okay, just focus on one. These are surrogate markers for the need to exercise more, for the need to stretch more, for the need to increase your flexibility and fluidity throughout the body. But I actually had somebody, after they read Peter Attia's book, they're like, oh, my grip strength wasn't good, so I'm just walking around with this gripper, and that's going to help my aging. No, it's not. That's not at all going to help your aging. You might have a better grip strength, but it's just a marker of the rest of your body being weak and in senescence and in atrophy. So just want to clarify some of those things there. Sensory function, is really important too. How well you see, how well you smell, how well you taste, how well you feel, and your balance. These are all extremely sensitive markers of your age, biological age, and your predicted mortality. Of course, other things like VO2 max and heart rate variability, all of these provide a much bigger, more in-depth picture of where somebody is at in their aging process and in their health process. Now, I'm very adamant and passionate about, look, if we want to live to 100, we have to start preconception. Whether or not we live to 100 has a lot to do with what our parents did before and during pregnancy, period. It's called the developmental origins of health and disease. And the first 1,000 days of your life, right, starting from conception and into 2 years of life, provide the greatest single input of whether you are likely to live long, or die young. And that is, there's no doubt, there's no scientific debate about that. There was just a study that was published in Science that looked at mother's blood sugar, and when the mother had elevated blood sugar during pregnancy, that was the greatest negative influence on the baby's metabolism and metabolic health for the rest of that baby's life, even after you adjusted for postnatal diet. So the higher the levels, even if postnatal diet was great during gestation, that is putting permanent epigenetic marks on your genes. And if you think about it, the baby's genes, they are sensing the environment, and it's wanting to prepare that organism, for what it thinks it's going to meet the rest of its life. So it's sensing the environment so that it can adapt. But these adaptations can be very negative if they're getting negative inputs, like elevated blood sugar, elevated CRP, inflammation, sedentary life, a lot of lipids and bad fats. That is negatively programming the baby's epigenetics for the rest of its life. So we're going to look at phenotype markers today and what you can look at, but I can't in good conscience mention health and longevity science without the crucial aspect of preconception. So most of us probably didn't benefit from preconception science. My patients do, and that's one of my favorite things that I love to do is to treat people of reproductive age and get them super healthy, because I know this is the future of our species. This is the greatest impact we can have on the future of our species. So most of us, living to 120 is probably out of reach. But if we can start now and work with the adults now and get them super healthy, then their kids and their children will have, their children's children will have a chance to live to 120, even 150, which is what we're really genetically programmed to live. So, and when you're looking at these composite markers, look at your lifestyle, diet, sleep, occupation, relationship status, cognitive factors like memory and executive function tests. So So that is the bigger picture of longevity science. Now let's go specific into the most important biomarkers that we can run on a daily basis. So I have the Lundell biomarker score. And if anyone's interested in this, they can email me and I'll give you the worksheet. Right now, like I said, I'm developing an AI program and an app, but it's much more detailed and involved and many tens of thousands of dollars that we're in the middle of. But it's a biomarker score that takes all of these things that I just talked about, but specifically these biomarkers, and we weight them. So based on the science, based on how much they influence or are reflective of cellular function, we give them a weighted score. So critical longevity markers these are weighted 3 times above the average: homocysteine, CRP, hemoglobin A1C, IGF-1, IL-6, albumin, creatinine, liver enzymes, and glucose. These are the critical longevity markers. The important metabolic markers, which still get twice the weight: reverse T3, ferritin, uric acid, fibrinogen, DHEA, which is super important in immune and inflammatory function, fasting insulin, your omega-3 index, and vitamin D. Standard health markers are still really important. So I'm not saying these are not important. These are extremely important. These are your standard longevity markers. Things like your red blood cells, white blood cells, MCB, absolute differential numbers, CMP components like bilirubin that haven't been already covered, your full thyroid panel, TSH, free T3, free T4, lipids like cholesterol, ANA and rheumatoid factor, which lowers your predictive lifespan, and then possibly incorporating this new test that Bill Beakey was talking about earlier, looking for infections, which is a huge piece of our aging. Epstein-Barr, cytomegalovirus, herpes, those all have been shown in the literature to affect our aging. So how we score it, again, I can give you the worksheet if you email me, and I'll give you my information at the end here, or in just a second. If it's within optimal range, not lab range, but optimal ranges that have been studied and vetted over the years. If it's outside of optimal, but within the reference range, you get 1 laboratory reference range, you get 1 point. If it's outside of the reference range, you get 2 points. If it's critically high or low, you get 3 points. And then with the final score calculation, you get the sum of the points possible times the category multipliers, depending on where they're at. In my lab panel, your maximum points is around 168, and I'll go through what my lab panel is. It's the Lundell Super Panel 1. So you get your final score divided by that times 99, and you get your likelihood of living to 100, a healthy 100. And 21 to 40 is I mean, really, it's 0 is the best, but 21 to 40 you still have a good likelihood. 41 to 60 decreased likelihood. 61 to 80 significantly decreased likelihood, and 81 to 100 you got some critical concerns there. You're probably not going to live like past a year or two, so that's your biomarker score based on your everyday tests that we'll go over here. So I've written a blood chemistry manual and your analysis manual for those of you that haven't, don't have it already. But these are my optimal levels that I've been studying for years. So you can go to my website, drbrandonlundell.com, and you can look at my online learning courses, and you can get the blood chemistry manual, or this is also part of my nutritional pathology certification course. You can get it by itself, or you'll get it as part of the whole course. But if you want the algorithm, it's still, you have to input it manually, but once you get the hang of it, it only takes about 5 to 10 minutes to do it, and you get a really good bio score. So this is the main components of the Lundell panel. You get your glucose. So this guy's score was, like an 80, not a good score at all. Uric acid is very high. That's another standard biomarker. Well, it's an important. I think uric acid gets a 2x. But hemoglobin A1C, that's a 3x. Glucose is a 3x. Calcium is a 1x, but it's outside of the range. Carbon dioxide is also a really important one because it shows mitochondrial function. If it's low mitochondrial function. If it's high, it often shows kidney issues and kidney disorders. So this is a case study. We're not going to go into this case study and exactly what we did. I'll go through a little bit, but we don't have the time to go deep into it. I will go more into this weekend. And even if you can't make it live, if you sign up and register and purchase the recording, then you can watch it. We'll have the recording a week or so later. So even if you can't attend live, you can still just go to my website and you can register on my website as well. Just go to upcoming seminars. Bilirubin is an important longevity marker. Total protein and albumin. Like I said, albumin was the greatest predictor of death if it starts to go down. But if it's high, it's a marker of dehydration, and that also significantly contributes to cellular senescence and inflammaging. He had elevated liver enzymes. That's a 3x. Ferritin, this high is a 3x. His vitamin D was okay, but his triglycerides. This guy had fatty liver, obviously, so not a good chance he's going to live to 100. Not a good chance this guy was going to live to 50, or 60. I think he was like 49 or something. But his CRP was also a little bit outside of the healthy range, which is 0.5 or lower. Homocysteine was also elevated. T3 was elevated for him. So you can see that, obviously we know he had a lot of clinical issues, but in terms of biological aging and biological score, which is kind of a buzzword and a lot of people are interested in it, you can greatly predict this guy's biological age. And, he was probably at least 10 to 15 years older than his chronological age. Fibrinogen activity was really low. Some of that can be genetic. Also, that is an inflammatory marker. It's also a marker of severe dysbiosis because the gut is taking up all of the fibrinogen to deal with that inflammatory and infectious milieu, if you will, right? The dysbiosis and sending signals. The fibrinogen is actually trying to fight that. So that's a critical marker for him too. His red blood cell indices showed a little dehydration, a little high on the red blood cell, but everything else looked okay. His RDW wasn't too high or too low. So, and his sedimentation rate wasn't too bad either. His urinalysis wasn't bad, although a lot of people have asymptomatic bladder infections and multifocal dysbiosis, right? The genitourinary tract has dysbiosis, which is always reflective of the gut dysbiosis, but this multifocal dysbiosis is huge. So inflammatory biomarkers, what are the specific? We're not going to go into all of them. That would take an entire day or two or a week, but let's go into some critical ones that I think are important to walk away with today, knowing how to interpret them and how to apply them. So these are the major classes. Your inflammatory markers, the CRP, interleukin-6, tumor necrosis factor alpha. These are things that all of these you can run through LabCorp. Bill, I don't know if you're listening or paying attention. I meant to ask you this before because I haven't. I know we talked about this, but I used to run interleukin panels. I don't know if the LabCorp still offers interleukin panels. I know you can just pick them out individually, but do they still have interleukin panels?
Well, we had to stop using those panels because of the agreement with National Jewish Lab, which was performing those. They just weren't getting enough of them to make it worth their while. And so LabCorp actually does all of those same markers at this point. I don't know if we have them put together in a panel as we did before, but they all are still there.
Yeah.
And
okay, great.
LabCorp is actually doing more of them.
Yeah, that's great. Yeah, and you can just choose individually. I think they're on average about $75 a piece. So these are the two. I do interleukin 4 sometimes too, but these are the ones that are really important. Interleukin 6, tumor necrosis factor alpha, and interleukin 4. But LabCorp has, last I checked, interleukin 1 beta, which is really important, interleukin 4, interleukin 10, interleukin 17, all of those you can do if you want. They start to get pricey the more you do, but it's tests that I run on, people that I think are really, at risk for severe disease, or they're experiencing severe diseases, or autoimmune, that kind of stuff. These metabolic markers, homocysteine, hemoglobin A1C, insulin-like growth factor, your CMP markers that we talked about, your oxidative stress and nutrient status. You can run a glutathione through LabCorp as well, glutathione test, just measuring the amount of glutathione. You can also do a G6PD, which is a good surrogate marker for glutathione in the red blood cell. A little bit cheaper and readily available. Vitamin D, obviously, and then some of your hormonal markers. So these are the ones that we'll kind of focus on today. And we'll kind of just go through these pretty quickly, because these markers aren't new to most of you out there, but I just want to recontext them and put them in the paradigm of your biological clock, which is new for a lot of people. And a lot of practitioners don't put them in that context. So the 3 critical markers of inflammation that I use, and according to the studies, I chose these because these have the most evidence behind them in terms of relating to biological age and morbidity and mortality. So some of these studies here, looking at cardiovascular disease, diabetes, neurodegenerative disorders, cancer, that kind of thing. And the thing about this that is important is that they're not just elevated overnight, so you can track these and see slight elevations if somebody is not functioning optimally. So long before disease happens, long before aging happens, or physical signs of aging, you can see how the cells are aging based on even small increases in the CRP, in the interleukin 6, and tumor necrosis factor alpha. And I also want to preface this, or inject this into your mind, that these are not the only 3. You can still have significant senescence and inflammation if these 3 are normal. There's other pathways. These just tend to be the most common, the most studied, and the most reflective of cellular function. But these are all rule-in tests, not rule-out tests. So you can't look at it and say, your CRP is fine, you don't have any inflammation. That's not accurate at all. This is, inflammation is an immune event, and just like the immune system, it has many different arms and spokes of the wheel. So while CRP is an important spoke, there are 50 others as well. So the low risk is the most important, where we want to be to function optimally, and that's less than 1 or even 0.5 is my cutoff value. Just some studies here showing its role in inflammation, its role in predicting cardiovascular disease, and how lowering CRP is becoming a very, very important, especially with long COVID. CRP predicted death was one of the highest correlates with death and comorbidities and comortality. So it really becomes an important marker. But how to interpret it, and how to treat it, and how to address the root causes is kind of what we're talking about. So this is an interesting study looking at, once released, so the production of CRP is a problem, but CRP in and of itself, why it's so damaging is it interacts with these DAMPs and PAMPs. So lipopolysaccharides, which come from the gut, and this study here showed, this study up here, it showed in biomedicine, it showed that lipopolysaccharides from the gut get into the bloodstream, acts as a PAMP, which is a pathogen-associated molecular pattern, or a DAMP, which is, viruses and bacteria, or viral and bacterial fragments, such as the spike protein fragments, and which is why people that have had COVID and the vaccine have severe cardiovascular events. And we'll talk a lot about that this weekend. Again, why are we seeing so much more cardiovascular events? I don't know about you, but the number of people in my practice that have had clots, heart attacks, healthy-ish, right? People that certainly wouldn't have had a heart attack pre-COVID, but because of either the vaccine or the COVID virus itself, or both, it activates CRP and continues to activate CRP. But not only that, but even low levels of CRP start interacting with the DAMPs and the PAMPs, and that's what causes the damage to the heart, damage to the blood vessels, and increases the risk for inflammation, heart attack, and stroke. So this process then leads to more production of IL-1 beta and IL-18, and this inflammatory microenvironment is self-promoting. Once it starts, it needs significant intervention for most people to stop. It does not self-resolve. It needs what we call resolvins, which is a class of anti-senolytic compounds, things like fish oils and stuff that we'll talk about today. But these are resolvins because this inflammatory aspect is what we understand about it now is that it is self-promoting. It's a feed-forward loop. It doesn't just resolve on its own. It does need intervention. It does need help. So a large meta-analysis in the Lancet was kind of a big landmark study that CRP is not a direct causal factor, but a valuable surrogate marker for also systemic inflammation. So this test showed, yes, it is a direct causal marker as well as a surrogate marker for many different diseases. CRP is related to memory and medial temporal brain volume in older adults. So the more CRP, the higher the CRP, the more it shrunk your brain and the more it damaged your brain. So, and I have studies about CRP and autism. Women who have higher levels of CRP, their babies are more likely to have neurodegenerative and immune disorders. So, truly, inflammaging and this inflammatory milieu is important. Now, we can go on and on about CRP. There's thousands, hundreds of thousands of studies, and we can go more into the mechanism. It's a little bit beyond the scope, and we only have about 20 more minutes, 15, 20 more minutes. But and we've got several others to go over, but it deserves a good chunk of investigating and understanding. So, interventions to lower CRP, first and foremost, you have to understand where the CRP is coming from. It can be, again, COVID, it can be infectious, it can be from leaky gut, that's probably the #1 cause. It can be self-promoting once it got started. It can be from an acute injury that turned chronic. You have to investigate. It can be from a sedentary lifestyle, it can be from a bad diet, all of these things. But it's not just nutraceuticals that can lower it. It's diet, it's exercise, it's all of these things. So this is just the highlights of things that have been studied the most and have the most evidence. So I wanted to present that to you today. Of course, your Mediterranean diet, omega-3 fatty acids, anti-inflammatory foods, vegetables, turmeric, ginger, the polyphenol-rich foods. Mindfulness and meditation, tremendous studies on how just mindfulness and yoga and the relaxation response dramatically lowers NF-kappa B and your proteomics, right? The proteomes of which CRP is one. Sleep hygiene is really important, although then inflammation affects how you sleep too, so that becomes a feed-forward problem. Inflammation interferes with quality sleep, and then quality sleep or lack of quality sleep raises your CRP levels. If you get 6 hours of sleep, your CRP level the next day is 3 to 5 times higher than your baseline, just from one night of not sleeping really well. Now, lying there thinking about this when you can't sleep is probably not going to help. But I'm not sleeping and now I'm more stressed because I feel my CRP. But just the importance of, all right, having good sleep hygiene and optimizing your circadian rhythm. One of the most important things. It's admittedly one of my weak links too. I'm a night owl, and so, you know, I need to have a very regimented sleep hygiene protocol. You know, turn off all my screens 2 to 3 hours, take a bath, stretch. Man, when I do my sleep hygiene protocol, it changes how I feel the next day dramatically. Curcumin, probiotics in and of themselves have been shown to lower CRP. Green tea extract and resveratrol. These are my favorites. These are the tried and trues, but here is important to always, and so I do a mentorship program, and I'm starting one in February where I take about 14 docs. This is a very small group, a very select group of doctors. There's a few spots left if you're interested in it, but we go through exactly how to implement all of these in a daily practice. That's different from my certification course. That's a program that you download and listen to, and it's 6 modules. This is where we have small groups in one-on-one sessions to help you implement wherever you're stuck in functional medicine, whether it's lab interpretation or, you know, minimal, you know, maximum doses, you know, how do we dose things, what labs to run, how do we interpret them, how to hire and train staff, whatever you're dealing with in your functional medicine world, we help you through that. But minimum effective doses, MEDs, are really important, and we go through this a lot in the mentorship class. I give a lot of that in my certification course as well, the nutritional pathology certification course. But this mentorship is about, hey, you know, you need 400 milligrams minimum. You know, you need 200 milligrams of EGCG. And a lot of people don't know how to dose it. And supplement companies aren't great at giving you, you know, how many you should take and for what patients and for what presentation. So understanding that is extremely, extremely important. Okay, interleukin-6, a key player in chronic inflammation as well. I'll go through this pretty quick because it's related to CRP, although it can be different. IL-6 is a core component of what we call the senescence-associated secretory phenotype, or SASPs. What does these quote-unquote zombie cells or senescent cells that are there, they're not turning over, but they're not functioning very well, and they are contributing to disease and to aging and to abnormal function. So these SASPs are a collection of pro-inflammatory cytokines, growth factors, and proteases secreted by these senescent cells. Very, very accurate in predicting how your cells are functioning and what your biological age is when it's looked at the bigger picture. So we'll talk about some of the senolytics, the things that reduce or resolve these SASPs. So this is another landmark paper looking at IL-6 as a critical driver of inflammaging, one of the top predictive biomarkers of inflammaging. And they demonstrated that persistent IL-6 secretion from senescent cells amplifies inflammatory signaling, promotes tissue damage and dysfunction over time. So it's got a link to cognitive decline for sure. It's got its implications in immunity. It's got implications in cholesterol and atherosclerosis, coronary artery disease, osteoporosis. I've long said this, that osteoporosis is an inflammatory disorder. It's not a frickin' calcium deficiency by itself. It's, you know, it just irritates me, these common misconceptions that are out there, even among functional medicine practitioners. Oh, you just need more vitamin D and more calcium. Well, that's important. What's destroying the bone more than anything is this inflammation. We have receptors called rankle receptors that when there's interleukins and CRP present, stimulates osteoclastic activity. And that is the #1 cause of osteoporosis, not lack of estrogens. Again, these are pieces, but these are secondary pieces. Inflammation is the main driver for most people. And forget DEXA scans. DEXA scans are highly unreliable for bone health. Yes, it can tell you if you're severely osteoporotic, but it doesn't tell you where it came from. It doesn't tell you how to resolve it. And remember, 80% of the bone is cartilage and soft tissue. Only 20% of the bone is mineralization. And that is all DEXA scans tell you, is mineralization. So I'll go more into that this weekend as well. And also hormones and how that's another pet peeve of mine is how people are doing hormone replacement therapy. 95% of people out there are doing it, I'm just going to say it, completely wrong. Even among functional medicine practitioners. It's not about replacement, it's about restoration and understanding of functional endocrinology. So it's not about just production, it's about how the cells respond to the hormone as well. Interleukin-6 becomes a really important biomarker, and very similar resolvins, right? Moderate intensity exercises, curcumin, resveratrol, green tea, omega-3 fatty acids, probiotics, stress reduction techniques. These are just some of the studies that that we have. Tumor necrosis factor alpha is similar but different, distinct. Tumor necrosis factor alpha contributes significantly to the SASP as well, and it amplifies other inflammatory signals. In this study, critical reviews in eukaryotic gene expression, this tumor necrosis factor is one of the main chronic inflammatory conditions or proteins in rheumatoid arthritis, inflammatory bowel disease, Alzheimer's. But it's a little unique in that some people, we want to target it a little bit different. So some of these are the same, omega-3 fatty acids, but tumor necrosis factor alpha, there's a lot of genes that are associated with tumor necrosis factor alpha production. And so here we want to target more of the methylation pathways to suppress these inflammatory genes, specifically in the tumor necrosis factor alpha. So if you have tumor necrosis factor alpha and elevated homocysteine, that really becomes more of an issue and amplifies each other. So curcumin, another great one, obviously, but you need at least 1,000 milligrams, and you need it twice a day. That's the other important thing that we'll go over is area under the curve and increasing your area under the curve when you're doing nutraceuticals. People that take it once a day don't really get a lot of benefit. The other one that I don't list here because I just didn't have space is broccoli seeds, so sulforaphane. Sulforaphane is phenomenal at reducing these inflammatory cytokines. So resveratrol, one of my favorites, probiotics, and grapeseed extract, but we'll go into that in a minute too. Homocysteine, I'm not going to talk too much about this. It's not new. We know, most of us know how to address homocysteine and methylation and making sure that we have enough methylated B vitamins, and if we need it, trimethylglycine and those kinds of things. But just some studies here also looking at, lowering homocysteine reduces your disease risk by 20 to 40%. Statin drugs can not even touch that. And yet everyone is given a statin drug when they have or suspected cardiovascular disease. Not one person in a medical office is given B vitamins to lower homocysteine. It is just a perfect reflection of how messed up our laboratory and functional and medical system is, because this is far more predictive of heart disease and far more of an easy and cheap medical intervention without the side effects, negative side effects that statins have. So I just had a patient yesterday, in fact, he had AFib, and he was going to Johns Hopkins and St. Joseph's in Baltimore and Maryland, top cardiovascular clinics in the world. They ran the homocysteine, and and it was like 14. They never mentioned it. They never gave him any intervention. He saw 4 different cardiovascular, and he's now on 6 different medications: a beta blocker, statin drug for his AFib, blood thinners, you name it. It just calcium channel blockers. None of them addressed methylation, which is really one of the main causes of AFib. And so if you're interested in AFib, come to that course this weekend. So we'll talk about AFib. I talk a lot about AFib in my nutritional pathology course as well. So we're seeing more and more of it. And we all know that for each 5 micromole per liter increase in plasma homocysteine is associated with a 40% increased risk of dementia starting from 6. So from 6 to 11, you doubled your risk of developing Alzheimer's and dementia. So hemoglobin A1C, a huge, huge marker. This gets into the glycosylations or the glycomics. Hemoglobin A1C is a glycosylation end product. And so it is a good surrogate marker for these other glycosylated end products, even more than your fasting blood sugar. So the point here, I would say, the take home here is that the studies show very clearly that a hemoglobin A1C of 5.2 and a fasting blood sugar between 75 and 85 is the target for 90% of people. So 5.2. Now, again, there are differences among Blacks and African Americans, all right? Asians, they tend to have higher baseline levels of hemoglobin A1C, but that doesn't mean that they're at higher risk for diabetes. It's just that genetically they produce more of the hemoglobin A1C. So you do have to sometimes be careful about that. Also, when you are taking a lot of antioxidants, your red blood cells last longer and they experience more glycosylation. So you get this sort of artificial rise in hemoglobin A1C that doesn't necessarily reflect your overall risk. So from a functional medicine standpoint, even a hemoglobin A1C of 5.4, if all these other, or 5.5 even, if all these other markers are okay, your fasting blood sugar and insulin and all that stuff, then that just means that your glycation is still good. Your red blood cells are just lasting longer, so you have a different reference range. So, what is important here is in this study, glycated hemoglobin and death from all causes were found to have a J-shaped association curve. So too low, below 4.8, your all-cause mortality starts to go up. But then if you get above 5.5, oh, then it starts to go up as well. So in this study, 5 to 5.5 was the sweet spot, somewhere in there. So hence 5.2. But yes, it's that J-shaped curve where, yep, low hemoglobin A1C is not good because you still need glycation. And then, you have to think about, well, what causes low hemoglobin A1C? Oftentimes severe anemias or cancers or things like that. So, not, you can't just say lower the better in hemoglobin A1C. All right, but in terms of Alzheimer's and cognitive function, blood sugar, as Dr. Perlmutter wrote in his book many years ago, the Grain Brain, and the studies have just kept building to corroborate that. Blood sugar status is the most predictive and pathogenic marker of brain diabetes or diabetes type 3 or Alzheimer's disease. So to lower, of course, anti-inflammatory diet and intermittent fasting, time-restricted eating, combination of aerobic and exercise, aerobic and lifting is far better than just lifting by itself or just cardio by itself. A few of my favorites: berberine, and alpha lipoic acid, so much evidence with these, and grapeseed extract as well. So grapeseed extract is one of my favorite. If you've listened to me speak, you know that that's true. I love grapeseed extract. It is easy to absorb, it's relatively inexpensive, and it's phenomenal in its anti-inflammatory effects. So I take at least 600 milligrams a day as a preventative dose of grapeseed extract of proanthocyanidins. Oxidative stress and nutrient status, these are also pillars of aging and cellular health. Glutathione is, as we know, one of the most important antioxidants that we have. And what I'll mention here is that we know glutathione levels decline significantly with age, and it does contribute to disease susceptibility, and studies have shown replenishing glutathione does reverse aging. So it's one thing to have a marker of aging, but does reducing that marker, much like grip strength, right? Okay, grip strength's a marker of aging, but does improving grip strength by itself really do anything? Well, in these markers, yes, it does, because glutathione has such global effects. And what I'll tell you is a lot of people don't know this. So my clinical pearl about glutathione is that glutathione itself, when you take glutathione as a molecule, does not get into the cell itself. There are no receptors and no transport mechanisms that we know of. It's been studied. They can hijack a few other receptors, but there's no receptors and intracellular transport mechanisms for glutathione, meaning glutathione's a big molecule. It cannot get into the cell. And so the body has to break it down and then transport those individual glycine, cysteine, and glutamine molecules inside the cell. It's very costly to take glutathione. It's much more expensive than the individual amino acids. And the rate limiting step of glutathione, we want glutathione inside the cell. That's where it protects your mitochondria. That's where it protects your genes. That's where it protects your protein structures. So N-acetylcysteine or cysteine becomes the rate limiting step. And N-acetylcysteine, there's a transporter for cysteine called the excitatory amino acid transporters. And every cell in the body has rich transporters. That's why cysteine is so effective at increasing intracellular glutathione. So my point is that I rarely use glutathione as a molecule in and of itself in my practice. I use the precursors. Studies are very consistent that that is what raises intracellular glutathione much better, much cheaper than, much more cost effective, we'll say, than glutathione itself. Now, there are times to use glutathione in and of itself clinically. Acute exposures to chemicals, it's great at binding, right? And chelating heavy metals and chemicals and protecting your extracellular environment. So glutathione extracellularly is also effective. So I'm not saying not to use it, but N-acetylcysteine tends to be more effective for intracellular glutathione. So at the very least, doing both. I never use glutathione by itself. That is, you're wasting your money if you're doing that. And I usually only do glutathione as an IV or as a sublingual if you need it for short periods of time. So that's my clinical pearl there, and I've got the studies to back it up. Okay, I'll move on. Measuring glutathione, you can do total glutathione concentration. You can do the GSH to GSSG ratio to see if it's being oxidized. These also are good surrogate markers. G6PD right here. Oops. G6PD, selenium, GGT, actually interesting in the literature, is a good marker of glutathione status. ALT and AST if glutathione is really low. So if you don't want to spend the $79 to test the glutathione, you can do that. But NAC is the most important precursor. Now here's the recommended dose. This is minimal preventative dose, 600 to 1800 milligrams a day. If you are dealing with any kind of inflammation and disease, you must reach a minimum effective dose of 3000 milligrams a day. Anything less than that is really not going to reverse anything. So taking 600 to 1800 a day preventatively is great because we live in a very inflammatory world. But as a daily thing, or as a resolvin, or as an anti-inflammatory, you must do at least 3,000 milligrams a day. So that's NAC in the brain is phenomenal. I take it at night. It helps you sleep better. I take about 1,000 milligrams right before bed with some vitamin C and some resveratrol. Helps me sleep so much better every night. So you can get some dietary sources of N-acetylcysteine as well. Vitamin D, we've only got a few more minutes. What I'll say about vitamin D, I don't need to say much because we've already said it many times and many people. You need your cofactors, but one of the things that I always tell people is that there is also a reverse J curve in vitamin D all-cause mortality. Okay, this study has been repeated and repeated for many different countries and for different races and ethnicities. We all know that your odds ratio for dying is very high when your vitamin D is low, but what most people don't know is that even levels up here start to increase. So vitamin D, short term, and I superimpose the US ranges here. Down here is nanomoles, but in the US, the LabCorp reports it as nanograms per milliliter, not nanomoles per liter. So a lot of people read these studies and they go, oh yeah, 50 to 80 is perfect, right? Because that's the lowest all-cause mortality rate here. But that's using international numbers. I can't tell you how many researchers have actually done that, and clinicians. But when we look at LabCorp ranges, what we see here is that the greatest all-cause mortality is actually around 30 to 40, okay? That is where the greatest benefit in looking at this is 36. This is actually not, this should be this didn't get imposed correctly. Should be over. The 16 correlates with the 30. So sorry, when making this slide, that number got superimposed or moved a little bit. So, but right here, this should be 32 here to 40 here. Okay, that is the optimal range long term. Now, there are reasons to use high doses of vitamin D in acute situations, for a month or two, even longer. But long term, the higher the vitamin D, the greater the risk of all-cause mortality too. And there's several different mechanisms that I don't need to go into, but one is vitamin D resistance. The other is receptor shutdown, and what happens to the genes. It kind of gets used to high levels. Increased risks of sarcoidosis in some patients. So we're talking population-based averages. Everybody's different, but my patients, for most of them, I target around 40. 50 is fine too, because it's a slow growing J curve, but it grows. It grows significantly when vitamin D levels stay high over the course of years. Needing your cofactors, vitamin K, obviously, magnesium, really, really important. So hormonal biomarkers, we'll just finish up with this. Thyroid is so important, as we know, but people don't realize its effect on aging necessarily, but thyroid's impact on longevity in this review article really goes into how it modulates aging and SASPs and senolytics, which is why it's so important to keep your thyroid in optimal functioning. So not looking at just TSH, but T3, T4, and reverse T3 as well. So the biggest cause of thyroid problems that I've seen over the years, I've been in practice for 20 years, is endocrine disruptors, and also glycosylation end products, and autoimmune disease. Those are all, and leaky gut. Leaky gut's probably the single greatest negative effect on the thyroid and other endocrine glands as well. So DHEA, measuring DHEA in the blood is actually very effective. Saliva is effective too, but some hormones are better in saliva, some hormones are better in the blood. DHEA is good equally in the blood or the saliva. And so the lower the DHEA, also another good correlator with COVID deaths, speaking of COVID. But the lower the DHEA, the higher the risk of death. So many different studies showed that as well. And dosing, we do 25 to 50 milligrams or 50 to 100. 25 to 50 postmenopausally, premenopausally, probably less than that. It just depends on where they're at and why the DHEA is low in the first place, which usually comes down to adrenal health, adrenal function, and oxidative stress. So supporting your oxidative markers. So that's what we do to look at someone's biological age through these daily markers, hemoglobin A1C, CRP, and look at your baseline assessments, how we use it in my practice. We look at the baseline assessment, then we analyze, okay, how is it all interacting together? We give them the functional medicine, dietary supplements, exercises, meditations, hyperbaric, infrared, breathing exercises, all of that. And then you've got to retest and give it about 6 months. I don't like to test sooner than 6 months unless something is critically off. Then you want to make sure that things are progressing a little bit quicker than checking it every 6 months. So we've got some other things that I didn't talk about that are the microbiome and longevity, how important that is. I don't want to miss saying that and how important that is. Senolytic therapies that we're doing with infrared and red lights and hyperbaric and all of those kinds of things, and intermittent fasting and circadian rhythm optimization, as I mentioned. So really, what I wanted to do today was establish that, yes, biological age differs from chronological age, but what does that really mean for us in a daily practice? Do we need to buy these $800 or $1,000 tests? Well, no. Measuring biological age and rate of aging does provide critical evaluation and treatment tools. We have a lot of major advancements in biological clock of biomarkers, but these common blood markers are still reliable markers of aging without the significant costs and other things of these omic tests. Algorithms and machine learning improve the predictive accuracy as well as patient motivation. So start with the Lundell panel. Add your specialized testing as needed, interleukins, infectious panels, nutrient panels. Review all of the systems, not just individual markers. Implement your dietary, lifestyle, and nutraceutical interventions. Monitor every 3 to 6 months. Like I said, 3 if it's significant. 6 just to give patients enough time to actually implement everything, and that's how we do it, and that's how we get patients well and thriving, not just disease-free, but really thriving. All of my patients. COVID was a perfect example. The patients who had been seeing me for years prior to COVID, none of them got sick significantly. None of them got long COVID. All right. The idea of thriving will help you meet any demand that the world can throw at you. But that's really what functional medicine is about. Not treating a disease, not saying, oh, you've got autoimmune thyroid, let me treat it. It's allowing someone to truly thrive and look at the bigger picture. So if you're interested in really taking your functional medicine practice to the next 10 levels, I love doing this mentorship. This is different than my nutritional pathology course. You do not need to take my course, and you don't even need functional medicine training, whether you've had all of them, A4M, IFM, everything M, or you've had none. I meet you where you are, and I advance your practice way more than you can get going through any of these, distance learnings or IFM and A4M. All of those are great, but none of them teach you really how to implement functional medicine on a daily basis. So we get group coaching, we get one-on-one mentorship, clinical and practice management, guidance with labs, you're part of the nutritional pathology community. It's $600 a month for 6 months. And probably half, this is going to be, I think, my 4th or 5th cohort. From cohort to cohort, usually about half take it again because they got so much out of it. They're like, oh, I want to do this again. It just keeps skyrocketing their practice. So, so visit my website if you're interested. It is drbrandonlundell.com. You can call or email us as well. And, think of me as your guide, your mentor, your safety net, I'm here. You can benefit from my 20 years of practice and my passion for all of this. And as always, I thank Dr. Bill for, allowing me to speak and for everything that you do in allowing us to have affordable lab testing for our patients. What would we have done without you all these years? And if you're interested in a whole day with me, come spend the day with me on Saturday virtually, or you can get the recording too if you want. And thank you very much. I really appreciate it.
And thank you, Dr. Brandon Lundell, for a really unbelievably great presentation. Lots of stuff there to consider, and you can go back and watch this on our video library later today or tomorrow at the latest. The notes will also be there. Also, in the Master Series tab under our video library, there is a webinar with Dr. Lundell detailing how he uses his Lundell Super Panel #1, so you don't want to miss that either. Dr. Lundell's been a tremendous contributor here at Professional Co-op and in many other places as well. He's just an amazing clinician and a wonderful person who shares everything he knows. How much more can we ask?
Yeah, I don't know if you need to go, Bill. If there's any questions, I'd be happy to answer a few of those.
Really, I don't think there are any questions that I didn't answer during the session. And I apologize for some of the typos. Some people can't walk and chew gum at the same time. I can't type and watch a webinar at the same time. So sorry for that. And in the notes are his contact information. Those will be posted, and strongly recommend that, if you have time this Saturday, watch his seminar. It's great stuff. And we're not doing this just because, we're doing it because there's great things to happen there.
Yeah.
I hope you take that to heart and consider that. Want to wish you all happy holidays. We'll be back on January 16th with Ruth Chris, nurse practitioner. And I think that, one more thing I'll say, we talked a lot about senescent cells today. Good studies out there showing how hyperbaric oxygen therapy reduces senescent cells, and published in the journal Aging. Go figure.
Yeah, one of the most important clinical treatments that we do in my practice. I've had a hyperbaric oxygen chamber in my practice for 15 years now, and it continues to be more and more and more important as people get sicker and sicker. So hyperbaric oxygen is phenomenal because, hey, oxygen is the #1 medicine, right? Without oxygen, there's no life. And using it as a medicine, using it in higher amounts than is achievable in a normal daily life, it turns out to be one of the best medicines out there. So I love it.
Thanks once again to our wonderful friend, Dr. Brandon Lundell, and happy holidays to you all. We'll see you in January.
All right. Bye-bye.
Bye-bye.